So, if you are dealing with a loss of physical intimacy, and I mean, whether that's decreased sensation, pain, or just a total lack of arousal, modern medicine usually hands you a quick fix.
Right, yeah, like a Band-Aid.
Exactly. You get a synthetic hormone cream or maybe a temporary lubricant or some prescription medication, and it is always something manufactured in a lab somewhere. But what if the ultimate cure for that tissue degradation wasn't found in a pharmacy aisle?
Which is such a wild concept to wrap your head around at first.
It really is. What if the exact biological blueprint needed to rebuild that sensitive tissue from scratch is, well, currently circulating in your left arm right now?
Yeah, I mean, it fundamentally changes how we view healing because we have been conditioned for so long to think of medicine as this foreign intervention,
Right,
right?
you take a pill to fix the problem.
Exactly. But the concept we are looking at today completely flips that script. It relies entirely on the latent regenerative power that your body already produces perfectly. It's just, waiting to be concentrated and put to work.
And that is exactly the mission for this deep dive. You, the listener, have handed us this really fascinating stack of medical sources, clinic notes, and research papers centered on regenerative medicine in feminine sexual health.
Some really dense material in there, too.
Oh, for sure. Specifically, we are looking at platelet-rich plasma therapy, or PRP, and clinically, this is applied in a procedure known as the O shot. But, I mean, we are not here to just read a marketing brochure to you.
No, definitely not.
You want to know the actual science. So we are going to zoom all the way down to the molecular level today. We want to unpack exactly which physiological growth factors, and we're talking about PDGF, VEGF, EGF, and TGF-beta are actually driving the vascularization phase right after this injection happens.
And, to really understand those molecular factors, we have to establish the baseline condition from your sources first.
Okay, let's unpack that. What's the baseline?
Well, if you are listening to this, you or maybe someone you know might be dealing with female sexual dysfunction, vaginal dryness, or even like mild stress urinary incontinence.
Which are super common, but people don't talk about them much.
Right, they really don't. But those symptoms don't just appear out of nowhere. They generally share a common underlying structural root cause, which is a localized loss of blood flow and, well, tissue degradation.
Right, and the sources mention this is often triggered by aging or a decline in estrogen, especially around menopause, or even just the physical trauma of childbirth. But what does that degradation actually look like on a microscopic level?
It basically looks like a desertification of the tissue.
Hmm.
I mean, in a healthy, youthful state, the vaginal and clitoral tissues are just packed with these dense, intricate networks of microcapillaries.
Like a sponge almost.
Yeah, exactly like a sponge. And those tiny blood vessels supply oxygen and nutrients. But when estrogen drops or the tissue is repeatedly traumatized over time, those capillary networks literally shrivel up and die off.
Oh, wow. So
Uh,
they just disappear.
Essentially, yeah. The tissue becomes ischemic, which is the medical term meaning it is starved of blood. And without blood, the tissue thins out, it loses its elasticity, and the nerve endings just kind of lose their sensitivity.
So if the root cause of painful intercourse or a lack of physical arousal is a dead capillary network, then the solution isn't just to slather on a temporary lubricant.
Right, because that's not fixing the plumbing.
Exactly. The solution is to build a brand new capillary network from scratch.
Precisely. And that biological process is called angiogenesis. Basically, the creation of entirely new blood vessels from existing ones. And that is the absolute foundational step for the O shot.
So without it, nothing else matters.
Right. If you don't have angiogenesis, you do not have regeneration. It's that simple.
Okay, so let's look at the mechanics of how we actually kickstart that angiogenesis. Based on the clinic notes in your stack, the procedure starts with a completely standard blood draw from your arm.
Yeah, just like getting a routine physical.
And then that blood goes into a centrifuge, which spins it at this incredibly high speed, which I have to say is decidedly unglamorous. It just looks like a
Yeah.
noisy salad spinner in a lab.
It really does. But it's doing something crucial.
Right. The goal is to spin away all the red and white blood cells, leaving behind this highly concentrated serum of platelets sitting in clear plasma. And the clinical papers actually refer to this as liquid gold.
Yeah, and it earns that nickname because of the concentration. By separating out the plasma, the centrifuge concentrates your platelets to levels that are sometimes like 5 to 10 times higher than what is circulating naturally in your bloodstream.
Wow, 10 times.
Sometimes, yeah. And that concentrated serum is then injected directly into targeted areas. So typically the clitoris and the anterior vaginal wall, which is the area often associated with the G-spot.
Okay, I have to pause here because if you're listening, you might be having the exact same disconnect I had when I first read this.
Oh, about the scabs.
Yes. Aren't platelets just the things that make scabs? Like, if I get a paper cut, my platelets clump together to stop the bleeding? How on earth does injecting a microscopic scab maker into vaginal tissue help with sexual dysfunction?
It is a very common point of confusion. I mean, for a long time, even the medical community thought of platelets purely as the body's emergency sealants.
Just tiny biological quirks.
Exactly. And they do play a vital role in blood clotting, obviously. But recent cellular biology has revealed that platelets are also incredibly dense libraries of bioactive proteins.
Okay, bioactive proteins. So they do more than clot.
Way more. Inside every single platelet are these tiny structures called alpha granules.
Alpha granules, what exactly are those?
Think of them as molecular piñatas, just packed full of chemical messengers. When this highly concentrated platelet serum is injected into the tissue, the platelets encounter a totally new environment and physical stress.
Which freaks them out.
Basically, yes, it activates them. They degranulate, meaning those little piñatas burst wide open, and when they do, they flood the local tissue with a massive cascade of specific growth factors.
Oh, okay. So they aren't forming a scab at all down there. They are basically releasing a chemical distress beacon.
Yes, they are sending out these potent chemical signals that tell the dormant local stem cells to wake up, multiply, and start rebuilding the tissue.
Okay, that makes so much more sense. And that brings us right to the first major growth factor on the list you provided. Vascular endothelial growth factor, or VEGF.
Yes, the spark.
So what happens the second the specific protein bursts out of the alpha granule?
So VEGF is the primary trigger for the entire vascularization process. Its main target is a specific type of cell called an endothelial cell, which is the cell that forms the inner lining of your blood vessels.
Okay, the inner lining. Got it.
When VEGF is released into this dormant, starved tissue we talked about earlier, it acts as a highly specific chemical magnet. It physically binds to receptors on the surviving endothelial cells nearby and just commands them to start dividing and migrating toward the signal.
Wait, I want to visualize this. How does a single cell migrate to form a whole new blood vessel?
It's actually a fascinating mechanism. An existing capillary essentially has to loosen its walls first. Then a single cell, which we call a tip cell, breaks out and starts creeping forward through the tissue.
Just pushing its way through.
Yep, it's following the trail of VEGF, kind of like a bloodhound tracking a scent. And as it moves forward, other cells divide and follow right behind it, linking together to form a tiny hollow tube.
That is wild.
It is. And that tube is the physical manifestation of angiogenesis.
So what does that mean for the listener? I mean, if VEGF is physically growing these new microscopic tubes, what is the clinical result when you are dealing with something like dyspareunia, which is the clinical term for painful intercourse?
The clinical result is a massive influx of blood supply to tissue that has been starved for years. Your sources emphasize that the female sexual response is a highly coordinated system.
Right, it's not just a switch you flip.
Exactly. It requires rapid vascular engorgement. When you are aroused, blood needs to rush into the clitoral and vaginal tissue to create swelling.
And that swelling is what drives everything else, right?
Yes, that swelling creates natural mucosal lubrication and physically pushes the nerve endings closer to the surface to heighten sensitivity.
Okay, so if your original capillaries had shriveled up, that physical rush of blood was quite literally impossible. The plumbing was just broken.
Completely broken.
So VEGF is forcing the body to lay down brand new plumbing so the blood can actually reach the tissue again.
That is the core difference between this regenerative approach and a standard symptomatic treatment. Like an estrogen cream might thicken the surface slightly for a bit, but VEGF is fundamentally altering the microvascular health deep within the tissue.
It's a structural fix.
Exactly. It is physically restoring the anatomical structures that allow for natural engorgement and lubrication.
Okay, so VEGF has commanded the cells to march forward and form these new hollow tubes. But wait, if I think about this mechanically, if you have just grown a brand new capillary and it's essentially just a single layer of fresh, delicate cells linked together, what happens when your heart beats?
You're seeing the problem.
Yeah, because wouldn't forcing actual blood pressure through a flimsy new tube just make it burst or leak immediately?
You have hit on the exact biological vulnerability of angiogenesis. A newly sprouted capillary driven by VEGF alone is incredibly fragile. It is really just a raw, naked tube of endothelial cells.
So it needs backup.
Desperately. If it isn't rapidly reinforced, it will collapse, leak, or simply regress and disappear completely. And that is exactly where the second major protein from your sources comes into play. Platelet-derived growth factor, or PDGF.
So the body anticipates that vulnerability. That's smart. What is PDGF doing differently than VEGF then?
Well, where VEGF is focused on sprouting that delicate inner lining, PDGF is focused on the outer wall. PDGF is a potent mitogen.
I have to stop you there. A mitogen. I am not a cellular biologist. What is that actually doing?
Right, sorry. A mitogen is a chemical substance that encourages a cell to commence cell division, so triggering mitosis.
Okay, so it tells cells to multiply.
Exactly. And in this specific case, PDGF targets a different set of local cells, primarily fibroblasts and smooth muscle cells. It signals these cells to rapidly divide and migrate toward the newly formed, fragile capillaries.
And what do these fibroblasts and smooth muscle cells do once they arrive at the new capillary? Do they just sit there?
No, they actually wrap around it.
Oh.
Fibroblasts are the cells responsible for synthesizing collagen and the structural framework of tissues. And smooth muscle cells act like a corset around the blood vessel.
Oh, a corset. I like that visual.
So PDGF recruits these cells to physically wrap around the delicate new tube created by VEGF, laying down collagen and giving it the structural support it needs.
Ah, so it's a two-step plumbing process. VEGF lays down the delicate inner piping, and PDGF comes right behind it, wrapping that piping in protective layers so it can actually handle the heavy traffic of increased blood flow without failing.
That synergy is vital. I mean, without PDGF, the new vessels would never mature. But PDGF has another crucial function in this phase, too. The literature points out that it stimulates chemotaxis for immune cells.
Chemotaxis meaning another chemical magnet effect.
Yes, exactly. PDGF acts as a distress beacon that attracts macrophages, which are a type of specialized white blood cell.
Like the cleanup crew.
Right. These macrophages arrive to clean up any cellular debris from the injection. But more importantly, once they're activated by PDGF, they begin secreting our next critical factor, TGF-beta.
Transforming growth factor beta. Okay, so we have VEGF sprouting the vessels, PDGF reinforcing the walls, and now PDGF is calling in macrophages to release TGF-beta. It really is like a coordinated relay race.
It's beautifully complex, isn't it?
It is, but this actually raises a new issue for me. If we have all these growth factors aggressively telling cells to divide, multiply, and lay down new collagen, doesn't that get dangerous?
How do you mean?
Well, if I cut my arm and my body aggressively lays down a ton of collagen, I get a thick, rigid scar. How does the body prevent this rapid tissue generation from just turning the vaginal tissue into a mass of stiff scar tissue?
That is a brilliant question. And it is the exact reason TGF-beta is part of this cascade.
Yeah.
TGF-beta is a master regulator. Its primary role in this context is modulating the extracellular matrix.
The extracellular matrix, that's the material surrounding the cells, right?
Yes, think of it as a three-dimensional scaffolding made of collagen, elastin, and other proteins that basically hold all your cells in place.
Okay.
When you are healing rapidly, the fibroblasts, which we just mentioned were activated by PDGF, can get really overzealous. They want to dump collagen everywhere to fill in the gaps as quickly as possible.
And if they do that too fast...
If they do that in a disorganized way, you get a fibrotic scar. Because the scar is just highly disorganized, dense collagen.
And in intimate tissue, a rigid scar is the absolute last thing you want. You need elasticity, pliability, and sensitivity.
Exactly. And this is where TGF-beta steps in. It acts as an anti-proliferative factor for certain cells, meaning it tells them to slow down.
Ah, it hits the brakes.
Right. But more importantly, it organizes the process. If rapid healing without oversight leads to a messy patch job, TGF-beta acts like a master weaver. It ensures that as the new collagen is produced, it is aligned perfectly with the existing healthy tissue.
So it's constantly adjusting the tension on the work site. It's telling the fibroblasts, yes, lay down collagen to support these new blood vessels, but do it neatly and stop when the job is done.
Precisely. It prevents the breakdown of the newly formed healthy collagen while actively suppressing that aberrant, abnormal scarring process.
That's incredible.
It really is. It ensures the tissue remodeling results in flexible, resilient, functional tissue rather than a dense fibrotic mass. It's basically the regulatory brake pedal that balances the aggressive acceleration of VEGF and PDGF.
Which is absolutely critical for long-term comfort and function. Okay, so we've covered the internal plumbing. The vessels are sprouted, they're reinforced, and they're integrated into the surrounding tissue without scarring. But your stack of research includes one more major growth factor, EGF, or epidermal growth factor. Where does this fit in if the blood vessels are already built?
Well, if the first three factors are focused on the deeper tissue and the vascular networks, epidermal growth factor is focused on the mucosal surface.
The very top layer.
Right. EGF stimulates what we call epithelial cell differentiation and surface regeneration.
The epithelium being the outermost layer of the tissue.
Correct. When you have severe vaginal atrophy or a severe drop in estrogen, it isn't just the blood vessels that shrink. The actual mucosal lining of the vagina and clitoris thins out drastically.
Oh, so it becomes super delicate.
Very. It becomes fragile, prone to microtears, and unable to maintain a healthy pH or natural moisture.
I see. So you could have fantastic brand new blood vessels underneath, but if the surface layer is still paper thin and easily torn, the patient is still going to experience a lot of pain and discomfort.
Exactly. The foundation is good, but the roof is still leaking.
Yeah.
So EGF binds to receptors on the surface cells, specifically keratinocytes, and accelerates their turnover rate.
It forces them to regenerate.
Yes, it forces that epithelial layer to thicken up and become much more robust.
So EGF acts as the finishing touch. It's rebuilding that thick, protective, hydrated mucosal surface just to safeguard all the intricate vascular work that was just completed underneath.
That is a highly accurate way to synthesize the entire biological sequence, yeah.
Yeah.
You have this completely coordinated molecular dance, and it's all initiated by a single injection of your own concentrated platelets.
But look, if you are listening to this, you've probably tried over-the-counter solutions and been pretty frustrated by how fleeting they are. I mean, a synthetic cream works immediately, but it's gone in a few hours.
Right, it washes away.
Exactly. When we look at this complex biology, VEGF sprouting vessels, PDGF reinforcing them, TGF-beta organizing the scaffolding, EGF rebuilding the surface, it becomes incredibly obvious that this is not a magic wand.
And that is a vital point for managing expectations, which, honestly, the clinical sources emphasize heavily. The O-shot relies on physical, cellular construction. Your body cannot simply 3D print a mature capillary network in an afternoon.
Right. It takes time for cells to physically divide, migrate, and weave new collagen. So what is the actual timeline based on the clinical data?
When a patient receives this treatment, they might experience a very brief, immediate change. But this is usually due to localized vasodilation, which is just the widening of existing blood vessels in response to the physical injection itself and the sudden rush of fluid.
So it's just a temporary swelling effect.
Yeah, exactly. It's temporary. True neovascularization, the physical creation of new blood vessels driven by VEGF and PDGF, demands time.
So how long is the wait? Because it has to be frustrating to get a procedure and then just have to wait around for your cells to do the work.
It definitely requires patience. The initial structural changes and noticeable improvements, like a slight increase in natural lubrication or a reduction in stress and incontinence symptoms, generally begin to manifest around 3 to 4 weeks post-procedure.
Okay, a month to start noticing it.
Right. But the peak results, the point where the new collagen has fully integrated and the new vascular networks are mature and fully functional, typically takes 2 to 3 months to fully develop.
2 to 3 months. Wow, that is a significant biological reality check. But, I mean, what does that mean for you? Why go through the... Wait, well, it goes back to the difference between a Band-Aid and a cure.
Exactly.
The synthetic lubricant is a Band-Aid. The O-shot takes months to peak because it is fundamentally modifying your body's actual physiological environment.
Which is precisely why the clinical notes indicate that the benefits of this procedure typically last anywhere from 12 to 18 months.
A year to a year and a half?
Yep. Because the newly built tissue and vasculature are real, living structures, they have a lifespan. They will eventually succumb to the same natural aging, friction, and hormonal processes that degraded the original tissue.
Which is why patients often return for maintenance treatments, I assume.
Exactly. But for that year to a year and a half, the tissue is functionally younger.
Functionally younger. I love that. It really strips away the marketing jargon and gets down to the actual science of what is happening. We are using the body's own blueprint to basically turn back the clock on a microscopic level.
And it is important to highlight one final safety aspect mentioned in your sources too, because this procedure is completely autologous, meaning the active material is derived entirely from your own blood. The safety profile is highly favorable.
Right, because your body isn't going to attack its own growth factors.
Exactly. The risk of an allergic reaction or tissue rejection is essentially eliminated.
There are no foreign synthetic fillers for your immune system to fight off. It is just your own biology concentrated and redirected.
Yes. Now, the literature does note standard minor risks associated with any injection, such as, temporary swelling, spotting, or localized tenderness.
Yeah.
But these are generally self-limiting and resolve within days.
Just normal shot stuff.
Right. However, the efficacy isn't guaranteed in a vacuum. Some sources suggest that women with severely unaddressed systemic hormonal deficiencies might need concurrent hormone support.
And that makes perfect sense. I mean, if your overall systemic environment is incredibly hostile due to severe hormone imbalances, you might need to address that systemic issue to give these newly activated growth factors the optimal environment to succeed. You have to look at the whole system.
Absolutely. You can't plant a seed in toxic soil and expect it to thrive.
Good analogy. So let's step back and look at the whole picture we've uncovered today. You walk into a clinic, they take a simple blood draw, and they spin it down to isolate your platelets.
The liquid gold.
The liquid gold. Those platelets are injected and act like molecular piñatas bursting open with chemical signals. VEGF pulls endothelial cells forward to sprout new, delicate blood vessels.
Right.
PDGF acts as the reinforcement, signaling smooth muscle cells to wrap those vessels so they can handle blood pressure. TGF-beta acts as the master weaver, ensuring the rapid growth integrates perfectly without leaving restrictive scar tissue.
Beautifully summarized.
And finally, EGF regenerates the mucosal surface layer, making it resilient, thick, and healthy.
It is a remarkable cascading physiological mechanism. It definitely demands patience weeks to months to see the peak results of this cellular labor, but the outcome is a fundamental rebuilding of the vascular network that lasts for well over a year.
It really is remarkable, and honestly, it leaves us with a much broader, almost philosophical concept to ponder as we wrap up this deep dive.
Oh, I know where you're going with this.
Right. If simply concentrating our own blood's platelets can fundamentally rebuild entirely new vascular networks and restore physical function in such complex, intimate tissues, I mean, what are the actual limits of our body's own latent healing potential?
It really makes you wonder what else we might be able to repair if we just learn the right chemical language.
Precisely. We walk around every single day with the blueprints and the raw materials for profound physical regeneration just flowing silently through our veins. We are literally carrying the cure to our own tissue degradation. We just have to learn how to properly signal our own biology to get to work.
It's a very empowering thought.
It really is. Thank you for providing such a fascinating stack of clinical sources and for joining us on this deep dive into the microscopic, regenerative world of your own biology. Until next time.